We're going to look at the foot next. I'm going to have my patient bend her knee and put a cassette right underneath of her foot. Again, I'm going to get the unaffected leg slightly out of the way. You would want to use a sandbag. I'll show you that as we're finishing up, but you want to make sure that you have your sandbag handy to help hold your cassette in place. You can perform a foot either AP or AP axial. I'll show you the AP first. We would use a perpendicular central ray. So as far as centering, you can feel the base of the fifth metatarsal here. You'll follow that up to the top of the patient's foot and center 1 inch anterior here, which will equal the base of the third metatarsal. I'll also adjust my centering to be a little bit more medial, and then I'll have my patient lift her foot slightly to correct centering on the cassette. You can put your foot back down, and the sandbag to help hold the cassette in place. I'm going to open up the collimation to be within 1 inch of skin line on both the medial and lateral aspects of the patient's foot as well as the toes. However, you do not need to include 1 inch of collimation past the patient's calcaneus. So you're just looking for that collimation on these 3 sides. We're going to put our marker within the collimated light field on the lateral aspect of the patient's foot. Ask the patient to hold still, make sure that our patient is shielded, take our exposure, and our patient can relax. The more common projection that you will do, however, is the AP axial foot. In order to do that, we're going to angle our central ray 10 degrees towards the heel. And our centering is going to be the same as it was for the AP foot. So now I'll just adjust my centering to be at the base of the third metatarsal. I still have a sandbag in place to help hold my cassette. Angling the central ray is going to help reduce foreshortening in her foot, and it helps to open the tarso-metatarsal joint spaces within the midfoot. So this is the more common projection that you'll see. I have my right marker on the lateral aspect within the collimated field of view. Again, you want to make sure that you have 1 inch of collimation within skin line on the lateral, medial, and anterior portions of her foot. You do not have to include 1 inch of skin line beyond the calcaneus posteriorly, however. So I will have my patient hold still, take the exposure, and then the patient can relax. So typically you start doing a foot exam with an AP axial projection of the foot, and then you go into the medial rotation oblique of the foot. Very common mistake for students is that they will come in, and I'm going to take the cassette out from underneath of the patient. I would bring in a new cassette, put it right back underneath of the patient's foot. They completely forget to take off this angle of your central ray. So make sure now for the oblique projection, medial rotation of the foot, that your central ray is going to be perpendicular. Next part of positioning would be to internally or medially rotate the patient's entire foot. Again, we want to make sure that we're not just angling in the knee and leaving the foot flat on our image receptor. We want to make sure instead that we are internally rotating the knee and bringing the foot up so that it forms an angle with the image receptor. Your textbook says to rotate your foot in to an angle of 30 degrees. However, to get an accurate image, depending on the height of the arch of your patient's foot, you may need to rotate that foot more than the 30 degrees. So some patients could actually require an amount of angulation upwards of 60 degrees. For this demonstration, I'll show you with the 30 degrees, but know that dependent on the height of the patient's arch is going to influence how much you need to rotate your patient's foot. Now that I have my patient's foot adjusted, I'm going to fix the cassette if she can just lift her foot slightly. Centering, similar to the AP and AP axial foot, we're going to be at the base of the third metatarsal, and we can find that the way that I described in the AP projection. Straightening out my collimated light field. And then I just want to make sure that I have collimation open to include 1 inch on the medial, lateral aspects of her foot, as well as to be within 1 inch of skin of her toes. I do want to include the calcaneus, however, on this projection. So I'm also making sure that I have 1 inch beyond the calcaneus for the oblique projection. Place my right marker on the lateral aspect within the collimated field of view. Make sure that my patient is shielded. Have her hold still. Take the exposure. A less common projection, but one that you might see, would be the foot in oblique with lateral rotation. So I'll put my cassette underneath of our patient's foot, and instead of rotating medially, now I'm going to have our patient rotate the foot laterally. Get the cassette centered underneath of her foot. So when we're looking at that rotation, what I'm looking at is the angle from the plantar surface of the patient's foot to be at 30 degrees. So I have that rotated. Centering is going to be at the base of the third metatarsal. I'm going to have the patient lift the foot just a little bit to better center the central ray to the cassette. I'm going to place my marker on the lateral aspect of the foot, still ensuring that I have 1 inch of collimation on all 4 sides, including the calcaneus. I'll make sure the patient is shielded, hold still, take the exposure, and the patient can relax. The next projection that we'll talk about is the mediolateral or lateral projection of the foot. A common mistake that I see made at the clinical sites, I call it the lazy lateral. We let the patient's leg just drop out to the side so that the foot is generally in a lateral position. The more accurate positioning, however, I'm going to have you bring your leg back up, would be to have the patient roll completely onto their affected side towards me. We're going to extend the affected leg straight out, and the unaffected leg, you can either bring it anteriorly or posteriorly, whichever is more comfortable for your patient. So in this situation, I'll leave the unaffected leg anteriorly, looking at the affected leg down here. So I'm going to generally start to position the foot. Now, the biggest key is that we're going to have the plantar surface of the foot perpendicular to our image receptor. Your textbook does state not to have the patient's heel in contact with the image receptor. That may be true in a lot of cases. However, again, each person's foot is shaped differently, and so you may need that heel to be in contact with the image receptor in order to ensure that perpendicular relationship of the plantar surface of the foot to the image receptor. So right now my patient's not positioned very well. I do want my patient to dorsiflex the foot so that it's at a 90-degree angle. And again, I'm looking at the plantar surface of her foot here to be perpendicular with the image receptor. It looks pretty good. Patient's leg is dorsiflexed at 90 degrees, plantar surface is perpendicular. Centering is going to be at the base of the third metatarsal. Along the mid portion of the foot. So our collimation is going to include 1 inch beyond the skin line of the toes and the calcaneus, and 1 inch beyond the plantar surface of the foot, but that also includes 1 inch beyond the medial malleolus, proximally. Typically, our lateral foot projections are hung as though the patient is walking, so I'm going to place my marker anteriorly and superiorly this way so that your resulting image would be able to be hung correctly. I'll make sure that our patient is shielded, have the patient hold still, and take the exposure.